So my name is Homer Venters. I'm a physician, an epidemiologist, but my career is focused on this intersection or overlap between justice policy and justice involvement, health, and human rights, really, and how to reconfigure those very competing forces, very troubled forces in our country for better health outcomes and less mass incarceration. So I'll be brief about the, there we go. I'll talk a little bit about the organization I work with, COCHS, Community-Oriented Correctional Health Services, a little bit about data systems behind bars, because I think that, maybe I'll start with this. How many people here have ever been inside the health clinic of a jail or prison? Okay, all right, so a few hands. I think that it is, when we talk about healthcare behind bars and jails and prisons, as you all are very adept at discovering in other venues, the availability of data, the existence of data is often much less than you would expect. And then also the availability and the access to the data is marginal because these are generally paramilitary settings. So I'll talk a little bit about, I mean, they're all paramilitary settings, that's what they are. I'll talk a little bit about the data systems. I actually don't need to talk so much about the opioid crisis, but I do want to raise some questions and points that as I hear people, you all educating me about the opioid crisis here, talk or at least raise for discussion some ideas about how incarceration and justice involvement features into the disparities and who dies from opioid overdose in the state, and then talk just briefly about innovation. And I'm really eager to try and do this quickly so we can have some questions and get into the final panel, which is really going to be fantastic. So the organization COCHS I work with, we're a nonprofit, and so we, in some cases, provide technical assistance for jails and prisons that want to do a better job with healthcare. In some cases, we do it because a judge or some authority says we need a monitor and we need people who know this work to do it. We also do quite a bit of work in the policy area. So one of our policy objectives, something we've worked on in New York, and we've had a lot of discussions around the country since 2015, is this Medicaid waiver process and how these 1115 waivers get crafted state by state, and many of you here are much more expert than I am in this world. But my view or my involvement in this has to do, and COCH's involvement with this, is that we made a really egregious error in 1965 when we passed the Social Security Act and said we're not going to use any of these funds for people who are in these institutions. And what that meant was not just that the funds wouldn't flow in, but none of the oversight, none of the quality metrics would go in. And so we built a system of 3,000 county jails, 2,000 state prisons, and the care, the scope of care, the decisions about quality of care in all those places generally is left up to a sheriff or a commissioner of corrections. So when we see county jails farming out their health care to a staffing company, really, a private vendor, why wouldn't they? Nobody holds them to any set of national benchmarks on what they should or shouldn't do. Nobody finds out about all the health outcomes that happen behind bars. So this system that we created, that decision in 65, by the way, was 11 years before the right to health care was established. We have this court case you probably heard of, Estelle v. Gamble, where the Supreme Court said in, I think, 1976, every prisoner in the country should get health care, has to get health care. But we had already decided a decade earlier, we're not going to fund it. And then we're also not going to worry about the quality of it. So we really have done ourselves a great disservice, and a lot of what I hope to grow in COCHS, and COCHS has been doing for a long time, is trying to get at this core issue. So my background, I was the head doctor in the New York City jail system. I trained as a resident in social internal medicine, which is a program at Montefiore in the Bronx. A lot of my patients went to legal aid across the street, and then they'd come over and they had a hard time accessing our health service. So I started seeing patients. I hung out a shingle in the legal aid offices and learned a lot from patients about what it was like to be incarcerated at Rikers. I then spent a couple years investigating healthcare provided to ICE detainees, Immigration and Customs Enforcement, and then through that investigation as a fellow, ended up working at Rikers and work my way up the system there. One of the couple of things I'll just mention. One is Rikers had the first MAT program, medication assisted treatment program, in any jail in the country. The KEEP program is probably 25 years old now, but we've been doing methadone and buprenorphine for many, many years successfully. And it's a core part of saving people's lives and decreasing death, keeping the rates of death lower than national average in that system. We were one of the first big jails, maybe the first big jail, to get an EMR, electronic medical record. There are a lot of downsides to EMRs if you're a provider or a patient, which is everybody in the room probably is one or the other. But as a human rights tool, I have really come to be completely devoted to them. When we worked hard to document abuse of our patients, the only way we could do that in an aggregate way and address it without putting our staff at considerable risk to their physical safety was to make changes to the EMR that allowed us to put together variables associated with health outcomes, like say jaw fractures, with variables associated with risk, like you're an adolescent or you're a person of color or you're in solitary confinement, and run and build regression models that would allow us to produce, odds ratios and aggregate reports that were, together with the stories of real people, were irrefutable, at least to the Department of Justice. And reentry is a big part of what we worked on at Rikers. I think as we talk about jails and prisons in this country, reentry rarely happens, like reentry services are rarely available for people going through county jails. And so in this country we have about 12 million incarcerations a year, and about 11 million of those happen in county jails. And as I was learning over lunch, as states have overcrowded prisons, they actually pass laws to funnel more people into county jails. It's a cash transfer to the county jail, to the county, but county jails have fewer services, notably reentry is one of the important services they often lack, so that the state ends up spending less money per person per year. The county jail gets money in that they might not have gotten otherwise, and that whole process leads to fewer services for people, but particularly these people churning in and out of county jails. So this is a picture of the facility in LaGrange. I forgot what it's called. And so I'll use it as a backdrop for a couple of things. So the security service and the health services in many jails and prisons have they have different data systems. And so I just want to start with that. I was fortunate enough to work for a correctional health service that was independent, and there aren't many in the United States, but what that means is when I was the chief medical officer or the assistant commissioner of health for correctional health services, my boss was the commissioner of health in New York City. So I didn't work for the security service. But almost every place in this country, if we have 5,000 jails and prisons, probably, 4,900 of them, the health service works for the security service. That's a really important thing to put out there before we talk about data, because that gets at who controls the data. A lot of the research, we did probably 40 or 50 peer-reviewed studies when I was leading the correctional health service. None of those would have been possible if my boss was the corrections commissioner. And there's nothing, that's the only novel thing about him, was that other people can't publish that kind of data. So the security services in these places have a jail management system. So that's a standalone system that tracks who's coming in from arraignment, getting booked in. Are they coming in on a technical violation of parole? Are they coming in from the police? Lots of demographic information. A big part of their of these data systems has to do with risk classification. So do they have have they been identified as being part of a gang, for instance, or what did they have their prior experience in the jail or the prison? That data system is one silo of information. Then there's a lot of other security service, and when I say security, it could be the Department of Correction, it could be a sheriff, right? Another big and probably larger amount of data is on paper. That has to do with things like, was somebody injured, or did they get in trouble and get an infraction? Was there an infraction hearing? Some of that might be integrated with the jail management system, but some might not. That system then sometimes connects to the health services system, sometimes does not. And this is where I want to get into a little bit more detail. health systems in jails and prisons, we don't know, but I would guess about a third of them, maybe less, have an electronic medical record. Many of them have what they would call an electronic medical record, but is not a real EMR. And so what do I mean by that? Well, a lot of these for-profit staffing companies that provide health services, they will build a proprietary electronic something. And I mean proprietary, like they won't share with with anybody. When they lose the contract and another person comes in, nobody can get those records. But that thing often is not a real EMR. It doesn't integrate physical and behavioral health. Often it's mostly a medication ordering platform, and maybe a little bit of like the intake, the initial jail or prison intake, it might be on there. But a lot of these things called EMRs aren't really EMRs. And importantly, almost none of them are connected to the health information exchange for the state. And I just want to put that out there as a real shortfall. But when they exist, these EMRs do have the capacity to integrate all the care. We bought an off-the-shelf EMR, eClinicalWorks, back in 2010 or 11. It took us several years to implement it, but when we got it implemented, we had all of the physical health, all of the addiction service, all of the mental health integrated with dental, with specialty, with PT. That's possible to do. It's a lot of work. There are pharmacy and inventory systems, which are really important. A lot of the county jails have local pharmacy, local pharmacists have involvement in the local county jails. What I see when I go around is that often there's like a strange political component to it's a lot of money that goes into the buying of these medications. So it's not lost on people who gets the contract to provide those services and what kind of money they make. That also goes into what kind of medications are used inside the jails, what gets on and off of a formulary. It goes into this issue of MAT, right? If you think about these three types of MAT, we have bup, we have methadone, and we have Vivitrol. And so methadone has been around the longest. It's the most evidence-based. But it's one that often local pharmacies are not very keen to support that are already involved in some of the other work. And then I'll just say that there are also paper records usually for quality assurance and quality improvement. Most jails and prisons don't have real quality assurance or quality improvement. If they do, it's a set of metrics that are approximated from some very loose correctional standards that are not mandatory. There aren't that many. I think probably less than 10% of the jails or prisons have any HEDIS measures that are built into their like monthly or quarterly quality reports. And those are not, almost none of that information is public. So keeping in mind that these are 5,000 public places, right? They belong to the taxpayers of the state, the county, whatever. Almost none of the health outcomes, either in terms of how health care is delivered or the actual health outcomes about who died and who got hurt, are made public. So this is, I think the only thing I'll mention here is the third bullet there is where I've spent probably most of my career. It's the thing that's most anathema to the paramilitary organizations that run these places, the sheriffs and the departments of corrections, but that we do almost nothing in this country to document how jails and prisons confer health risks to people, but they do in profound ways that are directly attributable, linked to death. But we don't measure those, even though we would know how to. In any nursing home, any hospital, I mean, think about if a hospital said, you know what, we'd like to just report that people got infections. We don't want to say that the infections were, linked to us putting in a central line or a Swan-Ganz or having this procedure or that procedure. They don't get to do that, right? Because we care about those health outcomes. Every single day there are people who die behind bars in ways that are directly attributable to and obviously attributable to what happened behind bars, but we don't force these local places to do any of that. I'm just going to run through a quick clinical scenario. You can take a look up there. So this is kind of a setup, but who could tell me what the number one cause of death in jails is? Right, suicide, a lot of S, suicide, that's right. So this is on its face an opiate withdrawal issue, opiate treatment issue, but I want to put, but I put in this history of self-harm in this because the number one cause of death behind bars in county jails, there's 3,000 county jails in this country, is suicide. There's a complete shame on all of us. And it's because we don't offer evidence-based care either for substance use or for mental health crisis. We mess up both of them. We make things worse with both of them. This patient, so this is a gentleman who comes in within minutes, right? As soon as the LPN does most jails just do a cursory, like 20-minute health questionnaire with an LPN. Often it's in a crowded hallway. It's not any private setting. But even in that setting, people will often report that they use opiates on a daily basis. In most jails and prisons, this person will not get access to evidence-based care, that is MAT. The best that you could hope for in most jails is that they might get a shot of Vivitrol before they go home. But in most places, like over 95% of the time, somebody who looks like this would be put into forced withdrawal from opiates. So the question is, how will most jails treat this patient? The person will be forced into withdrawal. They may be given an antihistamine, right? Or a couple of antihistamines, some medicines to seemingly calm them down, but not anything to fundamentally treat their withdrawal symptoms. Where will this person be housed? Often, there's a wide spectrum of practices, but one of the things I will say is that patients who have health problems in jails and prisons are often put into isolation settings. Now I say isolation because nobody is saying let's put this person in solitary confinement to punish them. But often the place they are put is a cell with a locked door by themselves for 24 hours a day. There may be staff that come by and peer through a window pane. They may even jot down or ask them some perfunctory questions through the door. But what we've done in terms of engagement is take a person who needs loads of engagement and care and put them in a place where we know they'll get less and less and less of it. And then what tools are used to monitor symptoms? I raise that because, you know, these suicides that happen behind bars, the leading cause of death in jails, often involve a mix of behavioral health, a spectrum of behavioral health, and sometimes physical health problems. But often it's this mix of withdrawal from opiates or other substance use and a mental health crisis. Both are happening at once. So I have investigated quite a few deaths where somebody is using a tool for opiate withdrawal or alcohol withdrawal, like COCHS, the COCHS or the COWS are these two kind of common tools we use everywhere. The jail may actually have those forms, and they may be checking 3 times a day the person's vitals, and somebody's jotting down on the COCHS or the COWS, patient, like they have a low score, but the patient said they're suicidal, or they're going to hang up, or they threaten to hang up, or they threaten to harm themselves. And I point that out because patients who go into jails and prisons are at high risk for death because of an overlapping spectrum of behavioral health problems, of mental health crisis and addiction and many oftentimes physical health issues. But to the extent we offer them any treatment at all, it is usually just in one of these silos. It is, we'll monitor your symptoms for alcohol withdrawal or opiate withdrawal, or we'll throw you in a solitary, a cell called a mental health watch cell, which is an isolation cell because we don't want you to kill yourself. But we won't like think about both problems together. And that really is why jails have very high rates of suicide, often in the first week or so as people are contending with both a mental health crisis and a withdrawal concern. So I think I mentioned, so MAT, you know, I have been in probably 5 states in the last couple of months where the states are rolling out new MAT programs, medication-assisted treatment programs, usually in prisons, not in jails. Most jails are kind of pre-contemplative. But one of the things they're saying is that as part of their reform efforts, they will offer people MAT as they go home. So that's unethical. These are people that meet clinical criteria for receiving methadone or buprenorphine or Vivitrol if they want, but I would invoke the great research of Jody Rich at Brown, who found that, you know, they offered that very few, if any, of the people offered Vivitrol and methadone and bup selected Vivitrol. So our patients don't want it. But whatever the MAT is, we've decided that people who meet the clinical criteria for this medicine that saves lives, it's okay for us to deign to give it to them right before they go home and deny it to them the whole time they're incarcerated, except for the last 30 or 60 days. And that is what passes for reform right now in correctional health settings all over the country. Australia had a very good, we have good experience in New York City, but Australia had very good data to share with a 20-year experiment of giving everybody methadone the whole time they were in prison. And one of the things that's really compelling is access to methadone reduced all-cause mortality, not just mortality from overdose, but it's not rocket science. People will engage with their hepatitis C, their epilepsy, their diabetes treatment when they're not worried about how to get illicit heroin or Suboxone in the setting because nobody will treat them for their addiction. So I think that most data I've seen around the country is about a quarter of people going into jails and prisons have opiate use disorder. Now that could be more or less, it's very regional, and there might be some difference jails and prisons. It's probably more geographically regional, but it's a lot of people. Certainly far fewer than 10% of those people will ever get evidence-based treatment for that. And then I mentioned a little bit about how this forced withdrawal from opiates, we know even in the community that withdrawal is associated with a much higher risk of suicide. And so it's a real mark of how little we care about the incarcerated people and their death, that we literally take people who we know will have this problem, we put them in places where we know they will not get that treatment, and then we don't track when they die or why they died. So I would just want to talk a little about community linkage for this information. Because most places don't have EMRs in jails and prisons, and most of those EMRs, even if they do exist, aren't connected to the Health Information Exchange. And then to go one further, even if they are connected, they probably aren't set up to send out one of these ADT pings, an admission discharge transfer notice, which is to basically say, like, this person went from this system to this system to alert the community health provider. So most health providers won't know that somebody was incarcerated. Many jails in particular won't have the resources to, whether you're in a state that suspends Medicaid or revokes it, depending on the status of the person, probably won't be checking that. It's really only state prisons where people are for a long period of time, where they'll have the resources and the programs set up to think about Medicaid reactivation or enrollment before people go home. And that's important because many people are going home, there's the eligibility and the coverage, and then there's the real access to care. And so people are going back to communities where there may be only one FQHC, or they don't have 5 different options for safety net providers or pharmacies. And so to have Medicaid that's not active when people go home, FQHCs and safety net systems are very much under financial duress. And so they often will not see people and not provide care for recently incarcerated people, at least for the first week or two. And we know, I won't show the data, but we all know that the risk of death is much higher in the first 2 weeks post-incarceration for people coming out of jail and prison. The third part of this is how will the care he receives impact his health after jail? So this gets at another problem, which I haven't mentioned, which is that inside jails and prisons, the health services, correctional health services around the country are really compromised. And they're compromised because of this problem called dual loyalty, which I won't delve into too much. I talk a lot about it in the book, but when you see a doctor or a nurse or a psychologist or whoever working in a prison or a jail, what we don't often account for is the way in which their mission to care for their patients has been corroded or pressured by the security environment. And it can be pressured in big ways, like asking health staff to clear people to go into solitary confinement, right? That's not for their benefit. You're not helping that patient. You're actually being part of their punishment. It's unethical by all the kind of professional judgments, but it happens all the time. And there are little ways, like security staff whispering in your ear, don't give this person a albuterol inhaler. They don't have active asthma symptoms because maybe having an albuterol inhaler means you get front cuffed so you can reach your inhaler, and maybe security doesn't want you to have a front cuff because they think it's more dangerous. Little and big ways, dual loyalty really corrodes our relationship with our patients, and then our patients go home. And what have they just seen and learned about health systems? That doctors and nurses often aren't on their side. They're agents of the security service, and that really has a lasting impact. Yeah, I think I talked about that. I just want to talk one way in which data can be helpful from the inside matched to the outside. So we did a lot of analyses like this, but this one really, it goes towards something that was raised this morning, which is housing. So when we looked at the people that come to the jail the most often in New York City, so we were matching our jail records with community health records, what we found is that while about half of the people had a mental health problem, look at how many people had alcohol issues, and then it's just really, we think of the prevalence of mental health problems as driving problems after incarceration. And it's true, a lot of people do have mental health problems. But the problems with housing and the problems with addiction and the access to those really drives a lot of the churn, the back and forth and back and forth. And so that's why we've been really, in New York City, these are big cities, right? New York City, LA, Philly. We have figured out how to leverage local funds and Medicaid funds for supportive housing. And local health systems have also gotten involved because they see and I think in Buffalo and in Syracuse, there are really good programs going on now where local health systems have decided it's gonna help us promote health to invest in housing. You can't see this, I apologize, but I just remembered this one article. So we did a lot of Hep C treatment in the city jails. And so most city jails don't treat people for hepatitis C with the new agents, even though they're curative for a lot of patients. A lot of our patients can be cured of Hep C. We can take away the specter of hepatocellular carcinoma or cirrhosis, costly and deadly problems. But the way we implemented this and the way we convinced City Council to give us a lot of money for it is we said we will connect this with our health information exchange so that when people are coming in, we'll find out everybody who's in the middle of active treatment, and then we'll continue their treatment, we'll invest in it, and then we'll also, on the way out, connect them back to that system or a different system if need be. But hepatitis C is probably the second use case for, in my view, leveraging Medicaid funds and resources behind bars. The first is the opiate epidemic, because these are patients that we all want to spend a lot of money on so that we can save lives and actually save money down the road. That's some data about, actually when we looked at our reentry planning, somebody asked about data earlier in some of these programs. So a lot of reentry programs don't have very good data. And this is the world of corrections, whether you're in a prison or a jail, it's all numerators. All you get from people is like, we did this many things, right? We gave this many pills. We gave this many people were in puppies for prisoners and this many people, but you don't get many denominators. And so, when we tracked people who went through reentry services for HIV, because we had a lot of Ryan White resources, we were able to see that the people when people received reentry services as compared to when they didn't, they had higher rates of stable housing, lower rates of food insecurity, lower rates of ER utilization, and their viral loads were better controlled. Just two quick words and then I'll wrap up on the health risks of incarceration. So this is where I feel the most kind of passion and outrage about this world, which is that our patients, the people that go through these places, are harmed profoundly when they're there. And they're harmed in ways that reflect a system operating as designed. So when jails predominantly take people with a mental health crisis and put them in a cell by themselves, and that person ends up dead, that's a predictable outcome, right? When systems use brutality, physical use of force, beating, as a way to control people who are locked up, and otherwise have lost their autonomy, then the injuries and the physical and emotional trauma associated with that is predictable. Or the rate of sexual abuse that's incredibly high, most of it unreported. All of that's predictable. One of the things we spent a lot of time, we probably published 4 or 5 papers on this, was how often our patients sustain blows to the head. This is a health outcome that's completely hidden from this country. So when you hear people talk about TBI or CTE, for me, it's one of the great examples of the hypocrisy of our public health system in this country. So imagine how much you hear about TBI on Sundays, right? Because a quarterback gets hit in the head. Or the Departments of Veterans Affairs cares about it with people coming home from serving their country. Or youth sports, right? You get a lot of education. We measured the prevalence of TBI of patients coming into jail, which is about 50% of them. And then we measured the incidence of new TBI inside the jails, which was astronomical. And then we looked at how many of these things ever go to the hospital. And for our system, and I think it's in the Lancet, but what we saw is that only about half of these TBIs ever make it to the ED. Now that's important because let's say that's true nationally. I would say probably fewer than that nationally get to the hospital. What that means is all of these traumatic brain injuries are happening behind bars, tens of thousands a year, and our public health surveillance doesn't know about them. Now compound that with the fact that we have a Centers for Disease Control that is not involved in monitoring any of the health outcomes behind bars, right? They know about people who fall off skateboards. They know about injuries here and injuries there. They are absent, AWOL, when it comes to health outcomes of people with justice involvement. As is HHS, as are most of our state departments of health, whose job it is. But TBI is a great example of an outcome that we now know is linked to very important risks for dementia, for CTE. In the long term, in the medium term, there are relationship and depression and other mental health issues. In the short term, think about what happens with a kid who gets hit in the head at school. The CDC has an amazing tool for how they should go back to school, right? I used it in the jails because we tried to figure out, okay, if somebody gets knocked out by a CO, or another detainee, how could we even dare to think about how to reintegrate them into the mainstream of jail life? And we couldn't really do it. But when you look at what our country has devoted to just on this one clinical entity, resources, and then you look at how we don't even bother to track the health outcome for people behind bars, it really reveals not just the hypocrisy of what we've designed inside the boxes, but how we in the public health and epidemiology community are completely complicit in this. Solitary confinement, I'll just say, we built this regression analysis to show that we took our own EMR. This is when I really became in love with the EMR as a human rights tool. We looked at everybody who ever came through the jails. We then looked at who ever harmed themselves, physically harmed themselves, because as a primary care doctor, I feel a little like less confident talking about the mental health crisis. So just physical self-harm. And what we found, we built this regression model, we found that with 225,000 jail admissions, your odds of being in the self-harm cohort were 7 times higher if you were ever exposed to solitary confinement. And we used that data and some horrible outcomes to eliminate this practice for most people in the city jails, not all. I think that you all have a sense of the scope of incarceration and criminal justice involvement in your own state, so you don't need me to tell you about that, or the profound racial disparities in that. The opiate crisis, I think you all also are expert in. I think that I just want to leave you with a couple of ideas. One is that EMRs and the health information exchange, I believe in, I guess kind of as a physician, I believe in it on its own merits, but I really believe in it. I feel it, the thing I feel it so strongly about is that these are places, jails and prisons, where we've intentionally put them aside, right? We've kept them away from all prying eyes. And nobody who runs a jail or prison is gonna open those places up on their own. And for some reason, we in health and public health have decided we could be left outside the walls of those places. And so if we really think we care about, if we want to get up on stages and say we care about the opiate crisis, or we care about diabetes, or we care about traumatic brain injury, then we must figure out how to connect our systems to those systems. And one of the ways to do it is to mandate EMR adoption. And so there are counties all over the country that when they turn over contracts, they say, you have to come up with an EMR, you have to implement an EMR. It's hard, and as I said, a lot of times it's like a faux EMR, so that's something to guard against, but it's really critical to start connecting those data. Social service data and housing, I think it's kind of a more inside the weeds issue. I think that the care coordination, you know, we went through these iterations of health homes and DISRIPs, and we've had like all these waves of ways. How do we find in the communities patients with lots of needs, and then how do we integrate their care? And all of those seem to ignore this place where they both get a lot of care and then they come home from a lot of care. So I was talking with somebody at lunch who works with specialty courts. There are a lot of specialty courts, drug courts, mental health courts around the country, where a judge would like to know, you know, what is the person's real diagnosis? Or the program that everybody wants to send the patient to wants to know when was their last TB test, or have they had a psychosocial assessment, or probation wants a psychosocial assessment, where is it? Well, a lot of that stuff sits in jails. And without people in jails who are funded and have the job of coordinating not just reentry on the way home, but diversion, keeping people out, it's very hard to come up with alternative models. I'm going to stop there because I've lost track of time, but I really appreciate being here. I just, you know, I really appreciate all the thoughts and insights you all have shared, so thank you.